Hello, everyone, and welcome to our first module on pulmonary anatomy. So let's start by talking about the lobes of the lung. So the first thing you should know is that the right and left lung are both divided into lobes. And the right lung has 3 lobes and the left lung has 2 lobes. So let's look at this image on the screen here. The right lung, shown here, has an upper or superior lobe, and then it has a middle lobe, and then it has an inferior lobe. On the left side, because of the heart, there is no middle lobe. Instead, you simply have 2 lobes, a superior or upper lobe and an inferior or lower lobe. Now, also on the left side, you have a small structure called the lingula. It's not shown here, but it's about in this area. It's right next to the heart. A lingula means a tongue-like projection. So this is a small projection of the left lung that is sort of the homologue of the right lobe. And so if you want a handy mnemonic to remember the lobes of the lung, what a lot of people use is the left lung has less lobes and a lingula. And that's to remind you that the left lung has 2 lobes. Another important term to be familiar with is the carina. This is the carina right here. It's where the trachea branches into the left and right mainstem bronchi. And so you want to be familiar with this term because it comes up a lot when talking about respiratory or lung anatomy. So infections like pneumonia commonly involve a single lobe of the lung, and you should be able to diagnose very obvious lobar pneumonias on a chest x-ray. So let's talk about that right now. So shown on this slide is an example of a right upper lobe pneumonia, and hopefully you can see that this is what a normal lung looks like over here on the left side. But here in the upper right side, we have this white dense infiltrate. That's called a consolidation of the upper lobe of the lung. And this is an example of a right upper lobe consolidation that you would see in someone who has right upper lobe pneumonia. In this slide, I've shown you an example of a right middle lobe consolidation. So once again, the left lung over here looks normal. The right lung is normal around the top, and you can also see a little normal piece down here at the bottom. But in the middle of the right lung, you have this white infiltrate or consolidation. And it's even easier to see on the lateral view. The lateral view is very helpful for middle lobe consolidations or middle lobe pneumonias. And you can see right here that you've got this wedge-shaped infiltrate, and that's consistent with a right middle lobe pneumonia. And then finally, on the right side, here's an example of a right lower lobe infiltrate. You can see this dense material here down at the bottom. The middle lobe here and the upper lobe are both clear. On the left side, remember there are only 2 lobes. So if you look at this picture, it's relatively clear over here on the right, but we've got this infiltrate in the left upper side. And then finally, this is a left lower lobe pneumonia. You can see this infiltrate right here in the left lower side. Now at the step 1, first and second year med student level, no one is expecting you to be a radiologist who can easily read chest x-rays. So you just want to be sure that you can identify classic examples of these lobar pneumonias. If they show you one on your exam, it's going to be very obvious. They're probably even going to give you a description of lung oscillatory findings in the question stem to help you figure out what lobe it is if you don't recognize it immediately from the chest x-ray. Let's talk about the anatomy of foreign body aspiration. So this commonly occurs in children. Children have smaller airways, and if they aspirate a peanut or like a watermelon seed, it can get lodged in the bronchi. And the first thing to know is that the right lung bronchi, are the more common site of aspiration. As you can see in this picture here, the left lung sort of has a sharp angle, but the right lung is sort of more of a straight shot. So that means when a foreign body is aspirated, it often goes to the right lung. And most commonly, as we'll talk about in a minute, it usually goes to this right mainstem bronchus. And this is because this is a more vertical path down into the lung. So about 60% of foreign body aspirations in most studies end up in the right lung, most of them in the right mainstem bronchus, which is right here. A smaller number end up in the right lower lobe bronchi, which are down here in this picture. A smaller number of cases, about 23% in most studies, end up in the left side of the respiratory tree. Also usually in the main bronchus, this is the left mainstem bronchus here, and a smaller number in the left lower lobe bronchi. Now let's talk about what happens when a person aspirates oropharyngeal or gastric contents. This is something you'll often see in the hospital when patients vomit. They sometimes swallow and aspirate some of those contents from the mouth and the stomach. And what will happen is the contents will go down into the lung, and they can cause either a pneumonitis, which is an inflammatory reaction, or sometimes a pneumonia. So what you want to know for your step 1 exam is which lobes of the lung are most likely to develop that pneumonitis or pneumonia if someone aspirates oropharyngeal or gastric contents. And which lobe gets involved depends on the position of the patient when they aspirate these fluids. So if the person is standing or sitting upright, then usually gravity simply pulls all the aspirated contents down into the right lower lobe here. That's pretty easy to understand. On the other hand, if the person is supine, so they're lying on their back, then it still usually goes to the right lower lobe, but it tends to go up to the superior portion or the uppermost portion of the right lower lobe. And then finally, if the person aspirates when they're lying on their right side or they're prone on their stomach, in these cases, the aspirated contents tend to go to the right upper lobe. Now, in actual practice, I've seen people aspirate in the hospital and all different lobes of the lung can be involved. So these rules are by no means fast and true all the time. These are just the most likely lobes of the lung to be involved when a person aspirates like described here. Okay, let's talk about the respiratory tract zones. So one way to divide up the respiratory tract is into the upper and lower respiratory tract. The upper tract involves structures like the nose and the throat and the larynx. The lower respiratory tract involves the trachea, bronchi, and lungs. And this is what we do clinically when we're talking about infections. We often talk about so-called upper respiratory tract infections or lower respiratory tract infections like pneumonia. But another way to divide the respiratory system up is in terms of zones. And when you do it that way, the conducting zones refers to the portions of the lung where there's no gas exchange. So this is everything from the nose to the pharynx and trachea, the primary bronchi, and the large airways. The role of these portions of the respiratory system are to filter air, warm air, and also humidify air, but no gas exchange occurs. And in terms of physiology, the conducting zone represents the anatomic dead space. This is an important concept I talk about in the pulmonary physiology modules, but dead space is areas of the lung that are ventilated, but they do not participate in gas exchange, and that's true for all the structures in the conducting zone. The other zone of the lung is the respiratory zone. This is where gas exchange occurs. So this includes structures like the respiratory bronchioles, the smallest bronchioles, the alveolar ducts, and the alveoli. This respiratory zone and these structures are sometimes called the lung parenchyma. Parenchyma means the functional tissue of an organ, not the connective tissue in other structures. So the functional tissue of the lungs that carries out gas exchange is all the structures found in the respiratory zone. Okay, let's talk about bronchi and bronchioles. So if we look at this little cartoon I've placed on the screen here, it shows how the respiratory tree branches into smaller and smaller conducting airways. So the trachea is a very large structure. That gives rise to bronchi, and the bronchi branch and branch and branch, and eventually they form very small structures called bronchioles. And the bronchioles are what eventually lead into the respiratory zone and the alveoli. So the bronchi contain cartilage. This is what makes them different from the bronchioles. There are so-called primary bronchi, which are found on the left and right side. That's the main stem bronchi here and also over here on the other side. That then divides into secondary or so-called lobar bronchi. These are bronchi that supply the different lobes like the upper, middle, and lower lobe of the right lung. Then you have the bronchi divide into so-called tertiary bronchi. These supply segments of the lung. So for example, the upper segment of the lower lobe. And one thing to know in terms of physiology is that the airway resistance turns out to be highest in the medium-sized bronchi. This is just sort of a quirk that you need to know about, but basically, when you get to the medium-sized bronchi down from the much bigger bronchi, the airflow begins to become turbulent and not laminar. This is a concept I talk about in some of the cardiology videos on flow mechanics. But when the airflow becomes turbulent and flows into these medium-sized vessels, that's where you get the most resistance to airflow. And this is just something they may want you to know for your board exams. Now, in contrast to the bronchi, the bronchioles are defined by the fact that they have no cartilage. The biggest bronchioles are called lobular or large bronchioles. Then you have terminal bronchioles. There are a large number of terminal bronchioles and they're arranged in parallel, and this gives them a very low airway resistance. And it turns out that this is the location of least airway resistance. And then finally, the smallest bronchioles are called the respiratory bronchioles. That's what feeds the alveoli. Let's talk about smooth muscle. So you can find smooth muscle in the conducting portions of the airways. Mostly you find it at the level of the trachea all the way down to the level of the terminal bronchioles. Proximally, like in the trachea, there's less smooth muscle. The trachea is mostly cartilage with just a little bit of smooth muscle. And then distally, like in the terminal bronchioles, you find lots of smooth muscle and less cartilage. And this is important for sympathetic and parasympathetic activity. Beta-2 receptors found on the smooth muscle in the lungs can be triggered by sympathetic activation, and this leads to bronchodilation. This is part of the sympathetic fight or flight response. You want the airways to dilate so more air can get in and out. In contrast, parasympathetic nerve fibers can activate M3 receptors, and this leads to bronchoconstriction. And this is basically a counterbalance to the sympathetic system. Let's talk about some of the airway cells that you can find lining the respiratory tree. And one of the most important types to be aware of are the ciliated epithelial cells. So this refers to epithelial cells with finger-like projections called cilia that beat to push debris out of the lungs into the mouth where it can then be swallowed. This basically keeps the airways free of dust and large forms of debris. The specific type of epithelial cells you find in the airways are pseudostratified columnar cells. What this means is that they're elongated cells, that's why they're called columnar, and they're pseudostratified. This means they're in a single layer, but it appears as if they're in multiple layers. And this is what you have happen when you have epithelial cells in a single layer, but they all have different shapes. So this is a cartoon of what it looks like here, and you can see that some of these cells have funny shapes and different shapes from some of the others. They're all elongated, so they're all columnar, but because they have different shapes, they take on that pseudostratified appearance. And then they all have cilia up here at the top because these are ciliated cells. And as I said, the cilia beat or move to push mucus into the epiglottis so it can be swallowed. And you find these ciliated epithelial cells at all levels from the bronchus all the way down to the beginning of the terminal bronchioles. So all these portions of the respiratory tree are lined with ciliated epithelial cells. And so back to this drawing we saw here, you can find cartilage. You can actually find cartilage in the trachea, but then you can find it in the bronchi, but you don't find it beyond the bronchi down in the bronchioles. Smooth muscle can be found everywhere from the trachea all the way down to the respiratory zone and the respiratory bronchioles. And then finally, cilia you find along the entire length of the respiratory tree, starting at the bronchi all the way down into the bronchioles. And here's an image of the distal respiratory tree just to give you a very clear picture of what that respiratory zone looks like. So remember, the terminal bronchioles are the last portion of the conducting zone. They give rise to these very small airways called respiratory bronchioles. Those give rise to alveolar ducts, which lead into the alveoli. And so all these structures here are part of the respiratory zone, and this is a depiction in this cartoon of what they look like. Let's talk about some other cells you find in the airways, and let's talk about goblet cells. So goblet cells are very important because they secrete mucus. Mucus is made up of glycoproteins and water. Glycoproteins are proteins with sugar molecules attached. They're very sticky, and this protects against particulates and also infection. Bacteria or large pieces of dust and other particulates will get trapped in this mucus, and then the cilia will push it all the way back up into the throat where it can be swallowed. And so in my little cartoon here, you can see these little goblet cells right here. They're producing mucus like you've got right here, and they're found close to the ciliated epithelial cells, which are all here. And you can find goblet cells all the way from the proximal respiratory system all the way down to the end of the bronchi, but you don't find them in the bronchioles. Bronchioles are very small structures, and if mucus were secreted there, they could easily get clogged up. But the bronchi are large enough to support the production of mucus, and that's where you find the goblet cells. Another cell type you can find in the airways are club cells. These are found in the bronchioles. These are epithelial cells, but they're not ciliated. And what they do is they secrete protective proteins. So this is part of defense of the respiratory system. They also have P450 enzymes, so they're capable of detoxifying some of the substances that can get trapped in the respiratory tree that are present in the air that we breathe. And so back to our little drawing of the respiratory system. So you can find ciliated epithelial cells all the way from the proximal system down into the terminal bronchioles. The goblet cells are found only in the bronchi. Remember, those are larger airways, and so they can tolerate the mucus produced by the goblet cells. And then finally, the club cells are found in the bronchioles. Those are those cells that carry out detoxification and have P450 enzymes. Let me give you a little bit more detail on the ciliated epithelial cells you find in the respiratory tree. So in the large airways like the trachea and the bronchi, that's where you find pseudostratified columnar epithelial cells, just like we talked about. This is also where you find goblet cells, and these large airways also contain cartilage. When you get down into the bronchioles, remember there's no cartilage in the bronchioles, but there is smooth muscle. And at this level, the epithelium starts to change. It starts to change from a simple columnar epithelial into a simple cuboidal epithelial. And by the time you get to the terminal bronchioles, that's where you find simple cuboidal epithelial cells. And the reason that this is happening is because by the time you get to the alveoli, you're going to have very thin cells that are responsible for gas exchange. So those large elongated columnar epithelial cells begin to shrink in size and become cuboidal as you get more and more distal in the respiratory tree. And then also, as I mentioned before, you find those club cells in the bronchioles. Those are the detoxifying cells that can take care of anything in the air that gets all the way down to the level of the bronchioles that might be toxic to the respiratory system. And then at the end of the respiratory tree, that's where you find the alveoli. So the alveoli are small sacs separated by walls called septa, and the epithelial lining of the alveoli is a simple squamous epithelium. And the epithelial cells you find in the alveoli are called pneumocytes. These are very thin epithelial cells. They allow for gas exchange, and they're surrounded by capillaries so that the capillaries can pick up oxygen from the air and get rid of carbon dioxide. This is a little picture of what one looks like here. You can see these little sacs separated by walls, and they've got capillaries all over them. And this is sort of a zoomed in version. You've got air in the middle with a capillary going alongside of it so that oxygen can go into the bloodstream and carbon dioxide can leave the bloodstream. So as I said, pneumocytes are the name that we give to the alveolar epithelial cells. If you look at this image on the screen, this is an alveolus here, and these cells lining it are the pneumocytes, or the alveolar epithelial cells. There are two types of alveolar epithelial cells. Type 1 is the most common type. This makes up 97% of alveolar epithelial cells, and these are very thin epithelial cells made for gas exchange. A smaller number of the epithelial cells are so-called type 2 pneumocytes. These have a very important role. They produce surfactant. And in other videos, I talk about how surfactant is necessary to modify the surface tension so that the alveoli don't collapse during respiration. In addition, the type 2 pneumocytes can proliferate to form other cell types, so they're very important for regeneration after injury. So this is a high-yield thing to know for your Step 1 exam. If they show you someone who had pneumonia and then a few weeks later the lungs are back to normal and they ask you, why did that happen? You need to be aware that the type 2 pneumocytes are very important for regenerating damaged lung tissue. And then finally, you should be aware that in the alveoli, you can also find macrophages, and these are important components of the immune system defense. And that concludes our first module on pulmonary anatomy.